Good afternoon. We are here with Dr. Daniel from Ann Arbor. He's a resident in Ann Arbor, and he recently published a paper with us. It's in production for JACC case report, whereby we'll hear about the case. Dr. Daniel is interested in cardiology. I'm Maurice Enriquez-Sarano. I'm associate editor of the JACC case report, and we will talk about this very interesting case of endocarditis. Dr. Daniel, if you want to summarize the case.
Thank you, Dr. Sarano. This was a case we recently had of a 54-year-old man that came to the hospital with fever and shortness of breath. Just initial investigation showed MSSA, methicillin-sensitive Staph aureus bacteremia, and overall, because his clinical picture was concerning for infective endocarditis, we got an echocardiogram that showed a large RV lead vegetation. And this was also confirmed by transecchocardiography. So because of this, he also has a medical history of like end-stage renal disease on hemodialysis. It was evaluated by the surgeons, and they deemed him a high surgical risk.
Can I interrupt you 1 second to ask you other comorbidities? This patient had an AICD, and the reason was?
So he had an AICD for primary prophylaxis, given his heart failure reduced ejection fraction. It was just for primary prophylaxis.
So many severe comorbidities that made him high risk for any form of intervention, in particular cardiac surgery. So you have reached this patient coming for shortness of breath and fever, and the patient has now a diagnosis of endocarditis with a vegetation that you see on transthoracic and transesophageal echo. It appears attached to the lead of the AICD. And what else did you do? Did you do a CT scan?
Oh, no, we didn't do a CT. We did a non-dedicated CT scan of his chest that showed some pulmonary infiltrates. So we thought this were septic emboli, but we didn't do like a dedicated cardiac CT. So based on the CT findings, we were really concerned about this vegetation. And as I said, we had asked the surgeons to review him for possible open extraction, but because of all of these comorbidities, it was deemed a high surgical risk. So he was evaluated by interventional cardiology, and we decided to pursue like a percutaneous extraction of this vegetation using.
Question for you before you continue. Question for you is was there any significant hemodynamic alteration related to the endocarditis, or was it just infection with vegetation? How did the patient present?
Gotcha. Thank you. So like when he came in, while he was not initially hemodynamically unstable, his blood pressure was already trending low, getting into the low 90s, high 80s. That's the systolic blood pressure. And I think the other consideration was the fact that it was having higher oxygen needs. It was getting increasingly hypoxic, and on top of the pulmonary infiltrates on the chest CT. So this was quite concerning. On the echocardiogram as well, he had this new right ventricular systolic dysfunction that was noted on echocardiogram that wasn't present on prior echoes. So this were like factors that were identified.
All right. So now describe to us the interventions that you conducted and the outcomes.
Thank you. Yeah, so we conducted a percutaneous mechanical aspiration of this vegetation. Traditionally, patients that have like large RV vegetation usually would have required like an open thoracotomy to take out this vegetation. And because he had an ICD, like in smaller vegetations, patients can have endovascular, like laser lead extraction, but the risk with that could be the risk of like trainer emboli, causing like worsened pulmonary embolism, or in fact worsening the septic emboli. So we performed this percutaneous aspiration using it's called a Flowtriever system. It's a thrombectomy system. Originally were designed for like extraction of pulmonary emboli, and an advantage to the system is it also has something called a flow saver system, which has like some filters, which has a filtration system that can help like filter blood samples and prevents like blood loss, particularly in a patient like us that had anemia of chronic disease. So we add 2 access points, one in the right internal jugular and then the right femoral vein as well. So the right internal jugular access was the main system with which we advanced our guide wire and passed on the Flowtriever catheter system. Initially, and the advantage of the Flowtriever system was like it had like a varying number of catheter sizes, and it's a large bore aspiration system that's helpful in cases where you have a large vegetations. So we initially had tried to use like a 24 French, but we was just aspirating blood. We couldn't aspirate the vegetation. We then switched to like a 20 French. Sometimes while the 20 French is smaller, we had better position with the vegetation, and in just one go, the entire vegetation was extracted. This was all under fluoroscopy guidance and under echocardiography guidance. We were able to like extract the vegetation. And at the same time, as I said earlier, the thrombectomy system does have a system in which you try to minimize blood loss. It has a flow saver system in which, as you're trying to aspirate blood can be returned through the right femoral vein access. So the patient is not losing blood, like in a patient that had anemia of chronic disease. And at the same time, you're not risking reintroducing infection because the system has what we call as micron filters, which I can get into.
This procedure of aspiration, you confirmed by echo that the visible vegetation was completely aspirated. And did you collect material from this aspiration?
Yes. Yeah. So we took material from the aspiration. We took the vegetation and we sent it for histopathology, and it did show like evidence of inflammation and bacteria colonies, confirming bacteria endocarditis. And yeah.
Was there culture done on the material or no culture, just examination?
Just examination. Unfortunately, the cultures they couldn't perform based on the way the specimen looked like. They couldn't grow any particular organisms.
So next day, if I understand well, you performed the extraction of the lead. And
yes,
and what was how did it go, and what was the outcome?
Yeah. So the next day, we performed like an endovascular laser extraction of the lead itself. While this could be done at the same time, but because this, for a lot of logistical reasons, the electrophysiology lab, the electrophysiologist had like competing had other emergencies, so this was scheduled for the next day. The lead was extracted safely, and the patients actually like responded well to intravenous antibiotics and was discharged home in a few days. Just in a few months afterwards, he had like fresh AICD reimplanted, and patient is currently doing great.
Excellent outcome. So the big question is, what does that add to the treatment of endocarditis? We know that when we treat endocarditis, the vegetations tend to decrease, and the diagnosis of thromboembolic events tends to decrease. And on the other hand, we know that the large vegetations tend to have a link to embolism. So we're up to now, the cardiologists have been conflicted in saying, okay, do I want to do an intervention now, even if there is no hemodynamic deterioration, to take out this big vegetation? Or do I wait with the antibiotics that the potential for embolism decreases over time. So what did you learn from this case in terms of that issue of balancing intervention and risk of embolization?
Yeah, thank you. That's a really relevant point. In patients that have large vegetation, they are less likely to have significant decrease in size with just IV antibiotics. And this actually teaches us, and from a few other limited case series, that this is effective and it's largely safe. It's percutaneous. It's not without its own risk, like every intervention. So I think it just sheds the body of knowledge that this is something we can pursue. It's minimally invasive. Patient can get quicker recovery, and it can prevent the need for open surgical procedures that can carry higher morbidity, mortality, increased length of stay, etc. So I think this is something we should continue to look into, and probably randomize patients and conduct randomized control trials to examine this.
That is very relevant. What your case is among a number of cases that have been published recently of aspiration of left-sided, right-sided vegetations in the context of endocarditis, and we don't know the benefit, but we know that your patient had already had embolism with lung and possibly abscess. We know that the patient tolerated the infection not very well because it was already hypotensive, and so this minimally invasive or transcatheter procedure has a potential to minimize the risk of embolization and minimize the risk of infectious syndrome. And I completely agree with what you're suggesting, that there is a clinical trial to do the traditional treatment of antibiotics and waiting for the vegetation to decrease versus the aspiration of a vegetation above a certain size, not the very small ones that are difficult, but above a certain size. We used to say 10 millimeters as high risk for embolization, but this number is a vague threshold. So really, we have to learn if this should be part of the absolute armamentarium for a given size of the vegetation of endocarditis to avoid thromboembolism, which on the left side can be devastating. So we have to determine safety and efficacy of these treatments. But these reports that are burgeoning, like yours, are suggestive of really a potential for benefit that should be evaluated thoroughly. Now, so we have the therapeutic benefit. Do we have also a diagnostic benefit if we see a vegetation and we don't have a bacteria? Do you think that this could lead to a bacteriologic diagnosis of endocarditis?
Yes. I think it's really helpful because traditionally, if you wanted to really get bacteriological diagnosis of specimens, you needed to do like an open thoracotomy. So this gives us empirical evidence of infective endocarditis as opposed to the uncertainty of whether it's like a vegetation or whether it's some other lesion. So I think it's a very important diagnostic tool as well.
Very good, very good. So in summary, a patient with a very high risk due to a number of cardiac and non-cardiac comorbidities, with endocarditis due to methicillin-sensitive germ and the staphylococcus and absorption aspiration of the vegetation in a patient with already embolism to minimize the risk of complication. And in fact, the patient improved very rapidly from the infectious side, and you were able to remove the material, and now is going to be re-equipped with a clean material on this patient. So a very good outcome and a very good management, and our congratulations for the
Thank you.
publication of this excellent paper,
Thanks,
and
Sarano.
for also your agreement to modify your paper according to all the requests of the reviewers and of the editors. So
Thank you.
we really appreciated working with you. Thank you
Thanks,
so
Dr.
much.
Sarano. Thank you. It's been a
Thank
pleasure.
you.